Welcome to my presentation. I'm Peter Gillett. I'm a consultant gastroenterologist from the Sick Kids Hospital in Edinburgh. Thank you very much for asking me to do this. I'm sorry that we're doing this in different circumstances to the original plan. My job in the next while is to give you a bit of a vision on paediatrics, a clearer view for children and young people. So I'm going to backtrack a little bit and give you a little bit of history, really. I know that the audience knows everything about everything, but it's not bad to just have a quick refresh. So we know that serology studies suggest that at least 1% of the population is celiac, and we now know that genes are very important. DQ2 and DQ8 are important, but clearly not the whole story. We know that gluten is a vital part of the triad, and we also know that it's been postulated and some evidence regarding specific, particularly viral triggers for this condition. Many are postulated. There is no universal trigger that's been described. Some studies do fail to show a significant increase in infections compared to siblings, and those are important too to realise, but also the importance of the microbiome and the environment. Just a little taster for later on. We know that from some data from the Prevent CD study, an important paediatric study, that around 17% of first-degree relatives that are followed in a very careful way are diagnosed by the age of about 9. And the biggest risk factor for being celiac is being female, having 2 first-degree relatives, and having 2 DQ2.5 types. When we look at the history of this condition, paediatricians have really been at the forefront of some of the newer strategies. ESPGHAN 1990 used to be a 3 biopsy schedule before that, and then the 1990 guideline let us do a single biopsy and then serology prior to that, but then follow up by symptomatic improvement and serology. We know over the years that antigliadin has not been terribly good, but clearly antigliadin IgG is making a comeback, particularly from our colleagues who deal with neurological conditions. And we know that antigliadin was superseded by endomysial antibody. We know that in 1997 anti-TTG emerged, and clearly it's a very important antibody both for diagnosis and for follow-up, particularly in children. We know that capsule biopsies have been succeeded by endoscopic biopsy, and now we know that D1 biopsies add a lot to the diagnostic armamentarium. And then all was good with the world. Since 1997, we've understood, because of TTG and DQ typing, that the pathophysiology is complicated, but the understanding has exploded. And we now know that the pathophysiology of celiac disease is very much gluten dependent. We know that there's an implied leakiness of the gut that allows your immune system, particularly when we're looking at DQ types on lymphocytes, to recognize or misrecognize that sequence. And then a catalogue of inflammatory events happens with loss of architecture. The analogy that we use in explaining to families is the lock and key, gluten being the key, and your DQ type on your lymphocytes or immune cell being key to opening up that category of inflammation. We know that ESPGHAN 2012 guidelines, when they came out, were controversial. In the UK, BISPGHAN and Coeliac UK made those guidelines more UK friendly, with 2 pathways, one for symptomatic children and the other for the asymptomatic at-risk children. Clearly, these guidelines rocked the boat with regards to management, and have taken a little bit of getting used to. Even for me, it was a leap of faith to go to the no biopsy strategy, but we've been doing this now for many years, and I think it's very important that we continue to finesse this. Clearly, our adult colleagues are thinking about grasping this too. We know from work that's been done that in a Scottish expression there are hunters of candidate genes, lots of different candidate genes noted, and work that's been presented at the Coeliac UK Research Conference by Iris Yonkers with an excellent presentation from a few years ago that would be definitely worth looking at. Going back to the at-risk children, these would be patients, as you can see, with type 1 diabetes and other thought to be increased risk conditions, where the DQ typing strategy was touted by ESPGHAN 2012 as a good introduction to trying to take children and young people out of the screening strategy if they had a negative type. I'm not going to go into detail about this, but this has clearly moved on somewhat. We know that DQ typing, although for a geneticist is probably a very simple phenomenon and thing to understand, it's quite difficult for general paediatricians and even simple GI gastroenterologists like me to actually grasp the nettle. And we know that there are important aspects of DQ typing for patient information. The ESPGHAN 2012 guideline clearly relied lots on DQ typing for a positive diagnosis, but clearly that has come out the mix in the most recent iteration, which I'll talk about in a second or two. We know that when you look at celiac populations, both in Australasia and also a cohort of patients from several centres and countries in Europe, that 99.6% of celiac patients carry either DQ 2.5, DQ 8, or DQ 2.2, or a combination thereof. Only 0.4% of celiac patients do not carry one of those DQ types, which really allows us to say with some certainty, although not absolutely, that if you don't have one of these types, that you're highly unlikely ever to be celiac. The other thing that we've clearly had to get to grips with is how we can look at risk profiling. So if you have two DQ 2.5s, you're at the highest risk, and so forth, going down this page to having one copy of HLA DQ 2.2, which is clearly a low risk, but not no risk. It's interesting that we mustn't always take for granted that 99.6, because when we look at DQ typing of celiac patients in other countries like Spain, we know that up to 3% might not carry those DQ types. So it's very important for us to be clear that this is not an absolute guarantee that you won't develop the condition, and interesting that it might vary from country to country. Also very interesting, and this is again from the group from Melbourne, that when you send a DQ type to a laboratory, you're very much dependent on the quality of the report that comes back. This is quite an insightful paper which looked at a quality assurance system and really detailed that some laboratories will not be reporting in the manner that we need to, and therefore we need to be very careful that we know if we're DQ typing still, that the report we're getting back is robust and able to be properly utilised. What about the at-risk group? Well, we're really talking about paediatrics still. Is DQ typing still relevant? And again, this will become relevant when we talk briefly about the new 2020 ESPGHAN guidelines. Well, we know when we look at various at-risk populations that only 6% of a type 1 diabetes population is negative for those DQ types, and therefore cost effectiveness has to be thought of when you're looking at the amount of money that you would spend on trying to take at-risk groups out of the mix, as it were. When we look at type 1, first degree relatives, something near 15% would be negative for those DQ types. Possibly the most helpful group would be the children and young people and adults with Down syndrome. So this paper that we presented at one of the previous Coeliac UK research meetings is being updated now. And although it looked as if it was around 50%, when we've looked at a further 80 or so patients, it's looking at around 40% negative rate. And that's still quite important for families that might be going on a journey where their child might have huge other problems to think about. And we think that this should be a standard of care, at least in the UK. This is being thought of by the Down Syndrome Medical Interest Group, and we're hoping to publish this in the next 6 months or so, when we've finished getting the rest of our Lothian population together. When we look at screening and prevent CD, so the group from Leiden, you'll see on this page that they've looked at first degree relatives. HLA typing in 335 relatives showed positivity in 87.5%. So that's very similar to the previous study that I showed you. What it's clear is that after the age of 10, if you're in an at-risk group, you're unlikely to develop the condition. Although there is more information going to come from Prevent CD, I'm sure, in the next year or so, which might look at giving us more information about whether that risk might extend beyond the age of 10. What this tells us is that if you're female, you are at highest risk. If you have 2 copies of DQ2, you're definitely in the high risk group. And around 25% of female DQ2 homozygous patients might develop the condition. What we've also found over the years is that when you look at laboratories within the UK, this is one of my colleagues, Siba Paul, who with a medical student looked at all of the laboratories in England performing anti-TTG titers. It was interesting that only 4 different assays were used, but there was a wide variation in the upper limit of normal. And therefore, for paediatricians and paediatric gastroenterologists, this could be highly confusing if, for example, you're looking at several different laboratories reporting tests within your region. And it can be very confusing. So although the no biopsy strategy has been welcomed by paediatric gastroenterologists and paediatricians and families alike, it's important for us to continue to make sure that our laboratory is reporting in a robust way, and that our histology is correlated well with that over 10 times the upper limit of normal. It's very clear from international studies that pathology reporting is one of the biggest issues. It's not serology, it's how biopsies are cut, it's whether D1 biopsies are reported in a standard fashion. And when you look at central laboratory reporting, it's clear that local laboratory reporting by pathologists can be quite variable. So when we look at guideline updates, clearly NICE looked to ask the UK population whether they felt that stakeholders were keen to update guidance on the basis of more recent evidence. It was put out to consultation, and unfortunately, and I think with some regret, they decided that they wouldn't be updating the guidance. So we're still left with 2015 guidance, and clearly, although paediatric populations are being managed with the new SGAN guidance, it was a little disappointing that they didn't feel that they should be updating it. So what about SGAN 2020? Well, these were published in January this year. They reviewed a lot of the questions that were raised by the NICE guideline of 2015, and the questions that were raised were based around that to answer some very pragmatic points. Clearly, in the light of evidence that had come through from the PROCEED study. So Werkstetter et al. Published in Gastroenterology in 2017. A German group published around a month or so sooner in the same journal, and the PROCEED study has really helped evidence the new SGAN guidelines. This rather busy slide, and forgive me for this, includes the table of 10 questions, but also the algorithm that's now been developed by the guideline group. I think it would be very useful for you to have a look at this and understand that there is an initial stage and then a stage where specialist involvement is required. It takes away the need for DQ typing, which I'll go into in another slide. It also details the importance of involving specialists when there is doubt, and also it's very, very clear that all IgA deficient patients, whether they have a positive G version of an antibody or not, require endoscopy to confirm the diagnosis. The main take-home messages are really that the main symptoms presenting for celiac disease are just as we expected, and you can see those on table 2, page 145. There is no need for DQ typing to make a positive diagnosis, as it clearly adds nothing to a positive diagnosis when you're looking at serological positivity over 10 times the upper limit of normal. The new guideline has introduced the possibility of discussion with a family about an asymptomatic patient being over 10 times the upper limit of normal. But actually, I think it has to be a very serious conversation. Clearly, if you're asymptomatic, your adherence may not be as good. And I think families really need to sign up to this. If not, and if they're going to have difficulty, then I would continue to look at biopsying those patients. We know that 2 separate tests are still being recommended, transglutaminase first, and then endomycel antibody. There are clearly areas of the UK and overseas who don't have easy access to endomycel antibody, and therefore, particularly in the UK, our BISPGAN group have suggested that a second transglutaminase antibody would be sufficient. We know that the cutoff is safe and robust for kids. As I've said to you, we know there's significant inter-observer variability in histology. We know that MARSH 0 and 1 and its natural evolution to celiac disease are a research topic that has been recommended, and I have some information for you a bit later. Certainly in children, there were no other relevant diagnoses missed, and I think that is quite reassuring. That may be different for adult groups who are thinking about this guideline and whether it will translate to adult practice, and I'm sure that it will be something that we will continue to debate. As I've said, everyone with IgA deficiency should be biopsied. So, what about the key pragmatic questions and trends? What have we actually taken from adult guidance from 2014? Well, David Sanders and colleagues set out the last iteration of adult guidance back in 2014. From my own personal point of view and dietitian's point of view, what we've taken from that is that we've started to use oats from the very beginning of diagnosis to give children and families a bit more variety in fibre intake. And it's very clear that oats are safe for the majority. What about other guidance that's come out in 2019 and 2020? Well, again, David Sanders and Jeremy Woodward, you clearly will be hearing from Jeremy about potentials and also the refractory and non-responsive group. But this has been a very helpful paper to focus even paediatric teams on what to look for when symptoms don't quite respond, even if serology improves. And an excellent paper again from the group with Dave Sanders with table 1 showing the other possibilities. I personally have just diagnosed my first patient with pancreatic insufficiency in 20 years. It's clearly rare in children, but not unheard of. Inflammatory bowel disease, particularly Crohn's, but also UC. We know that lactose and fructose intolerance can happen too. And in children, we know that food allergies, particularly milk, egg, and soy, could also be possible as co-diagnoses. Small intestinal bacterial overgrowth is definitely in the mix here. I have at least 2 patients with lymphocytic colitis who didn't respond to gluten-free diet and therefore made us go back and think again. Functional motility and IBS problems, I think, are the vast majority of my cases locally where things don't quite go back to normal. And I think we mustn't underestimate the importance of functional abdominal pains and symptomatology in our patient group. What about the potentials? These are children clearly with normal biopsies, Marsh 0 or 1, and with positive serology. Well, the group from Naples has published 2 excellent papers, one detailing what happens when you go gluten-free, when you're a potential celiac, and my take-home message from this is around 50% will get symptomatically better, but clearly not all will have resolution of symptoms. The other important paper coming out last year was what happens when you don't do gluten-free diet and you continue on gluten. Well, it's very clear that in the longer term, the progression to villus atrophy was around 43%. It might take a number of years, but it was certainly a progression. And this is really helpful information to give to families. What about the increasing awareness of neurological and psychological or psychiatric issues? I think this is a very important thread these days, and clearly something that's on the Coeliac UK research agenda. Well, there is no doubt that psychology plays a bigger and bigger role in patient management. This study would show that when you look for it and when you look carefully for it, you might find psychological issues in up to half of patients who are assessed in a multidisciplinary setting. And again, Marios Hadjivassiliou and the group from Sheffield have detailed psychiatric issues in a very good systematic review. Clearly for pediatrics, autistic spectrum disorder, OCD, ADHD, anxiety, eating disorders, specific disorders like ARFID becoming more and more important, anxiety issues, social phobia, going out, having had a bad experience and not wanting to do it again. Very, very clearly important for us to be detailing and looking at for our population. Okay, so what about the incidence of celiac disease? Has it now topped out despite the 1 in 100 mantra? Well, certainly evidence from Finland a few years ago would suggest that the trend of biopsy verified celiac disease is topping out. And it's an interesting bit of information also clearly from the Nottingham group, despite the fact that we're continuing to look more and more for the condition, that we're probably not picking up maybe as many as we expected. And that's certainly something to be looking at and clearly continuing to have a low threshold. It's very clear that certain areas have a very different incidence, and this is data from the 3 adult areas within Scotland. What about the exciting new diagnostics and new treatments? Well, clearly, even for children, this is a very important potential for helping out when families have gone gluten-free and clearly don't feel that they can go back onto a challenge. Clearly, this group from Oslo is looking very hard at adding diagnostic testing with a tetramer test to our armamentarium, and I think it will certainly benefit paediatric patients very much as well. Also, therapeutic options. What else beyond gluten-free? An excellent review by Umberto Volta and his group. This is something that's been very key in the paediatric setting. What about the role of peptides and how they fit in with assessment? Clearly not the same as a breathalyzer test and probably shouldn't be used that way, but clearly something that might be helpful when we've got patients who are not responding to what they think is a gluten-free diet. And I think the paediatric group within the UK is very keen to look at this to see how it fits into our armamentarium. What about now, and what about guideline misinterpretation? Well, it's very clear that even the current guidelines, the 2012 guidelines, were not properly adhered to. Certainly groups within the UK were using IgG diagnostics and extrapolating the IgA tests to those patients who were IgA deficient. And clearly the new ESPGHAN guideline has made it much clearer that we really feel that all selective IgA deficient patients should be biopsied. Clearly IgG antibodies are much more long-lived and pose difficulties in follow-up with multiple questions from regional groups asking whether the loss or the lack of loss of G antibody actually means anything. I think it's very important when you bring new guidelines out, and particularly the new 2020 guidelines with asymptomatic possibilities, that we have a handle on things from a central point of view and try not to let people go too far off-piste. Personalised care, I think, is very important for our future. Coeliac UK and BISCGAN met in October last year, and it is a work in progress to look at accommodating the new ESPGHAN 2020 guidance, but perhaps bolting on some pragmatic follow-up guidance and trying to make it personalised, trying to make it evidence-based, but probably it will be a position statement and hopefully pragmatic, avoiding too many tests and avoiding assumptions that we previously made that are probably incorrect. What about a children's and young person's agenda? Well, I think it's really important for us to have a think as a group, and this is the Celiac Disease Working Group from BISCGAN and Coeliac UK. We need to look at the bloods at baseline and follow-up. What do you really need for follow-up? What happens when your transglutaminase normalizes and then that family are absolutely nailed on gluten-free? Do you not do any more bloods when everything is resolved and just look for symptoms, or what? I think this is a work in progress. We need to look at pragmatic vitamin D and calcium advice. We need to answer the question about DEXA in children. I know it's a chestnut on the adult side, but actually there's some debate in pediatrics too. Who's for further follow-up when the dietitians are happy with you? Who's for further follow-up if there are medical problems? What about the psychological aspects? What about preparing people for adulthood, the goodbye advice? We, I think, forget as pediatricians to talk about pregnancy. We forget to talk about making sure that patients look at the Coeliac UK website and look for folate advice. And also clearly, another thing that's come into the fore recently regarding pneumococcal vaccination and who is actually hyposplenic, who is at risk of bacterial secondary infection. And it's very clear that not all adults who are advised to have pneumococcal vaccination actually get it. How can we make that all better? Advice for patients, GPs and other healthcare professionals about those other conditions that were highlighted in the Sanders and Woodward publications. What about more challenges? What about new innovations in informatics? What about helping celiac families in their self-care? Well, certainly within Scotland, through the NHS Inform website, we've tried to begin a process of more informatics, and that's co-produced by Coeliac UK and family members. I think this is the way forward, in my view anyway, to get better informatics. What about the Focus in CD group? Well, this is a European consortium who have produced some very helpful information which is available for all. In my view, it's a very European view on celiac disease, but some of the information is fabulously good and is worthwhile looking at what you should be using as healthcare professionals as to giving advice and information about the condition. Also, they've brought up the issue of a celiac passport, which certainly in our area we're looking at producing with the help of the charity that's involved at Sick Kids in Edinburgh. And we think that this is probably the way forward also, particularly for children. Even the thought of an ID card that you can use when eating out, or if you're in a situation where you need some official corroboration of your need for being gluten-free. What about the adult services in paediatrics? Certainly it's already happening in Finland, where they've embraced no biopsy, and this excellent publication by Fuchs et al. Showed that across all pretest probabilities, 33% of patients could probably, on the adult side, could probably get away without having a biopsy, without anything significant missed. Certainly within Scotland, this has become quite an important topic as part of a post-celiac test of change pathway project. A lot of enthusiasm to work collaboratively with the Scottish Society of Gastroenterology and our group. 5 boards in Scotland using 3 different anti-TTG assays, with dietitians and pathologists looking at a retrospective view, albeit retrospective, to see who really needed biopsy and what else would we miss, and what investigations we really need to do in follow-up, and looking at the outcomes at a year plus after going gluten-free, and also looking at how we can better educate and offer better ongoing support. I'm going back really to what I take as a very important statement that Dave Sanders made to me a while back, the 3 Ds of celiac disease. And I think many areas are still doing this. I think it's an indictment on all of us to try to not discharge and leave people in the wilderness, but to offer further support. So diagnose, dietitian, and discharge. Thank you, David, for that. I think it's a really important concept for us to try to support people if we're going to be discharging them, if we think it's safe to do so. And clearly, a Cinderella of gastroenterology. No one seems to care about celiac patients apart from the people that are watching this presentation. I think it's an indictment on us that we've reduced access to gluten-free products. We have made it more difficult in many ways for people to get follow-up. And I think it's an important thing, particularly in current times, for us to try to reverse this process. It's very clear in pediatric GI that patients who are lost to follow-up, this is a paper from some colleagues from Israel, it's very clear that lost to follow-up patients, 35% in this clinic, headed up by Ranan Shamir, were looked at again, and their adherence was clearly poor. Although it was using a Biagi, which it certainly has its limitations, it was very clear that this group really would have benefited from some form of follow-up or reminder system. As left to their own devices, you can see that adherence was less good. What about bringing it all together? Well, as I've said to you, between Coeliac UK and the BISCAN Coeliac Working Group, we're looking at reimagining the ESPGAN guidance, making it more UK friendly, and perhaps offering some more formal, pragmatic advice for follow-up. Certainly educational material and video education, I think, is very important. The ESPGAN Special Interest Group for Celiac Disease is looking at an incidence and prevalence study across ESPGAN, but clearly what's happened this year has probably put the kibosh on that. Optimal dietetic guidance is another work stream, I think, very much to be welcomed. Management of children and young people in follow-up is again another work stream that's on the go, and I think we should definitely be looking at how we can work together with adult colleagues in a closer fashion. Preparing young people for living alone and going out to further education and adulthood, I think, continues to be a key factor for all of us. What about solutions and maybe things to ponder? So paediatrics is traditionally a very maternalistic or paternalistic group. We like face-to-face, we like being involved, we like to feel that we are making a huge difference in management. The role of the doctor, I think, certainly within Scotland and within our Scottish paediatric celiac network, is changing. I don't think we're going to be the primary people anymore. We're going to be the go-to for an expert dietitian who is going to be the hub of management. The role of an expert dietitian with a hub and network system, I think, has to be the way forward, and regional networks offering support for families, perhaps as a regional service rather than based in any individual hospital. Within the current situation that we're in with COVID-19, do we need to think differently? Certainly group clinics, which I'm in favour of, are probably not on the cards at the moment, but looking at video and telephone, we're looking at a huge surge of video consultation being bought in, and for telephone clinics to be used when people can't come up to a hospital at the moment. Certainly, John Thompson, who's an adult gastroenterologist in Aberdeen, who really leads on digital health from a medical point of view in Scotland, talks about the carbon footprint of multiple clinic visits, certainly in geographical areas like Grampian. And I think it's a very, very interesting way to look at what we're doing and how we can do it differently. We're certainly using email much more from a service point of view, and there are ways around making sure that the Caldecott Guardians are happy with that. And then, of course, we're talking about patient-initiated follow-up, but looking at a way back if required. This is really the basic tenet of self-care, but giving people a backup when they need it, and perhaps having a reminder system too. So what about follow-up or other ways of doing it? And also collaborative research. Well, certainly the group from Sheffield, Matt Curian, Dave Sanders, with a Coeliac UK sponsored project, are now expanding this into the paediatric setting. And I think this is probably something that might be very exciting for young people as part of follow-up. Again, very keen to explore other ways of reminding people, asking people how they're doing, not only from a research point of view, but from a practical point of view too. Follow-up is clearly key, whether that's on a phone or by video. Certainly NHS Near Me, which is a video concept clearly from originating from Australia, is becoming more and more popular within particularly AHP settings through specialist nurse follow-up, but also dietetics. I think this is something that will be the future. The promotion of dietitians in management and involvement in research, I think, is absolutely key. Certainly within our Scottish network, we're very keen to do our incidence study. Strangely now, almost 11 years down the line, but making dietitians a central part of management and of research. And I think promoting our dietetic colleagues is absolutely key. And if you don't have enough dietetic support, like we have had to do in our area, keep banging on about it and telling people how much better value for money having a dietitian managing a patient is compared to a medic. I'm nearly finished, you'll be pleased to know. Gemma Oversby is a PhD student at Queen Margaret University in Edinburgh. I've put her details up here because she's very keen to hear from people to look at an intervention study that's unfortunately now going to be put on hold due to the current health crisis, but actually something I think to think about for the future. How do we intervene? How do we improve adherence, quality of life, patient-reported outcomes, and make people more ready for transition into adult life? Again, I'm sure Gemma would very much welcome interest from people who are looking at this presentation. So on a couple of final points, clearly we were vastly excited within the paediatric group to find that this year's awareness campaign was regarding children aged 5 to 11 years. I'm very hopeful that we can salvage something despite this current crisis. And clearly Heidi and all of our colleagues from Coeliac UK have put a huge amount of work into this. And we'd really like to explore as a group how we can make this happen despite the current crisis. I'm going to finish there. This is a shameless promotion of Jean-Michel Jarre. I've reacquainted myself during the last few days when I've been off work with his music, and clearly we're all in the spotlight. I thought this was quite a good way to finish off, and would very much welcome your questions and comments. If you have anything you want to get back to me about or any information, I'm more than happy for you to email me. I'm very happy to disseminate any of the papers that I've mentioned and take any questions or comments. Thank you very much.